But now let me introduce Noel Brewer from the University of North Carolina at Chapel Hill, who will talk to us about the increasing vaccination model. Noel.
Hey folks. So I'm going to talk today about the increasing vaccination model. It's work that I did with Julie Leask, Gretchen Chapman, Alex Rothman, and Ali Kemp. The model is primarily concerned with addressing low vaccination uptake. However, there are other things to consider. People also at times delay vaccination, and increasingly we're having to address instability in vaccination. Those are two other behaviors that are really important to keep track of, that is instability over time. But I'll be focusing today primarily on vaccine uptake. The paper that I'm going to be talking about appeared in Psychological Science, and it appears on the screen here. There's also a sort of a quick version of it, a short version that's suitable for lay people and practitioners that's available through the Vaccine Science and Policy Group at Sabin and at the Aspen Institute. So the model you've seen some version of already when Julie spoke. The basic model is that there are three chunks of things that motivate vaccination: what people think and feel, social processes, and direct behavior change. I'm going to go through each of these one by one. What people think and feel. So the proposition here is that what people's thoughts and feelings influence their vaccination behavior. And I'm going to go through the evidence for that, but let's first agree on what I mean by thoughts and feelings. It can be your disease risk appraisal. I'm concerned about getting pneumonia. Your vaccine confidence. The pneumonia vaccine is effective and safe. It could also be your motivation. I plan to get the pneumonia vaccine. I want to get it. I intend to get it. I would like to get it. And then finally, there's the behavior, which is getting the vaccine or refusing it or delaying it. So the thoughts and feelings part are all of these things over here on the left-hand side: the disease risk appraisal, the vaccine confidence, and the motivation. So the question becomes, is there support for such a model? And there's very strong support from correlational studies, studies that use non-experimental designs, that ask people questions all at the same time or look at them over time. However, when we look at evidence from randomized trials, the evidence looks fairly different. Evidence on messages that increase disease risk appraisal show failure in that area. We do not have strong evidence that messages that increase disease risk appraisal increase vaccination uptake. There is some scattered evidence, but there's a recent meta-analysis, for example, by Parsons, showing that that is not a way that's effective currently for increasing vaccine uptake. Educational campaigns that increase vaccine confidence. Now, this is a murkier area. It may actually be that this works, but we don't have a trial that ties all this together, that says, we tried to increase confidence, here's how we changed it, and that is now associated with vaccination uptake. So it could actually work. We just don't actually have the evidence that says that confidence, what people think and feel, is the driver there. Decision aids are not effective in increasing uptake, and then motivational interviewing has some promising evidence, but we don't have randomized controlled trial evidence. We have other different kinds of evidence available at this point. So moving on to social processes, these are a little bit more complicated, but the proposition here, the second one, is that social processes influence vaccination. Now, let me go through what I mean by social processes. You have a social space. You have your social network, the people you talk to at work, or these days it's online. It could be a social network. It could be people that you talk to in your neighborhood. We are very much alike the people that we hang out with. It's called homophily. So birds of a feather flock together. And our ideas propagate through our social network and generate social norms in people's minds. Those social norms can then guide vaccination behavior. Other things are created as well. There are social preferences that we have. For example, altruism, wanting to help other people, vaccinate to help other people, or possibly saying, I'm going to free ride. I know other people are getting vaccinated, so why should I bother? All of these can be associated with vaccination refusal. Now the question becomes, what's the support for a proposition like this, that social processes are central to all of this? Well, there's strong support from correlational studies and some sort of quirky experimental lab type studies. But when it comes to the randomized controlled trial evidence, there's not a lot. Now notice here that the open circles are no or minimal evidence, as we saw for the thinking and feeling. But when we get to social processes, descriptive norm messages, we do think are pretty promising. It's worked in other areas. We just haven't seen the right kind of data yet, the strong data in the area of vaccination. similar social network interventions that build on contagion, that could be very promising. It certainly worked well in other areas. We just haven't quite seen it yet in vaccination, or at least the trials that I've seen have not yet been published. But I believe the data are out there that convincingly show that this is a promising area. So now there's a third way of thinking about how we might change behavior, and that is to change behavior directly, to not try to change what people think and feel, to not try to change the social world that they live in, but instead to just build on whatever their good intentions are or not, and then just change behavior without changing what they think and feel. And so the version that builds on favorable intentions helps to keep vaccination on people's minds with reminders, prompts, and primes, or tries to reduce barriers with logistics or behavioral defaults. But it could be that you decide that's not good enough. We're going to need to twist some arms. And in that case, you just shape behavior using incentives, sanctions, and perhaps through using requirements for vaccination that some call mandates. There is very clear evidence from intervention studies for Proposition 3. The data are shown here, and there's quite a lot, and I'm going to give a few examples here because it's such an important area. But presumptive healthcare provider recommendations, reminder, recall, the only reason why that's not a solid one, we know it works. It turns out that primary care does not a good job of actually doing these, but Ali Kemp has data showing that if you centralize it, it's effective, as long as you use the name of the clinic on the centralized reminder recall. Implementation intentions, mere measurement, on-site vaccination, default appointments, incentives, also sanctions, and then vaccination requirements, or as we call them sometimes, mandates. So here's some data from a trial that I did. It's based on a hypothesis by Doug Opel, that if you assume that parents are ready to go and you use that language to introduce a vaccine, that its uptake will be higher. So we trained providers in 30 clinics in North Carolina, and in the intervention arm, HPV vaccine uptake was about 5% higher in the folks who were trained to use presumptive announcements, to announce the child is due for vaccination at the start of the visit, and then pivot if need be to more consultative interactions. If instead we train them to start off with the consultative interactions, what we find is that there is no statistically significant increase. That's the gray bar. There's a series of nice trials by Gretchen Chapman, also co-author on this work, and she finds that if you set the default that people have an appointment, you just schedule them for an appointment for a seasonal flu vaccine, they're more likely to come in. And that's the opt-in on the left, and in the middle is the opt-in, where they're given the option of coming in. And if you don't send any letter at all, it looks like the same thing as giving them the opt-in. What's also really important is that overall vaccination is increasing. It's not just what happens in the clinic. When you look in the registry and so on in their medical records, it actually is overall an increase. And so she has she and her colleagues have a couple different ways they've done this. And then finally, this is a nice study that was done in India, randomly assigning villages to control, to a monthly vaccination camp, or to a monthly vaccination camp with incentives, either that included a kilogram of lentils per shot, it's worth about 3/4 of a day's wage, and then a set of metal tally plates at the completion. And you can see here that the vaccination rates are a little higher when there's this sort of on-site vaccination provided, but even higher when there's incentives provided on top of that. And this is by a recent Nobel laureate. So coming back to the model here, what looks promising? Well, in my opinion, what people think and feel is not so promising as a way to directly change vaccine uptake, although I'm going to come back to that because it's an important area. Social processes are really promising, understudied, and poorly understood, at least in the area of vaccination. We could create whole journals just on this topic. It's an area that we need to fund and we need to conduct research in. And finally, direct behavior change is what we should be doing now. This is what we know works, and these approaches are underutilized. There is a great opportunity for using this. I will also note that a lot of the data that I presented are from high-income country settings, the US, Western Europe, Australia, and so on. However, there is a great need for data on low and middle income country settings, and I'm particularly excited by the work of BESD and others at the World Health Organization and these others on this call who are doing work in low and middle income countries to understand what their strengths are, and perhaps some of those strengths could be brought to other countries as well, including high income countries. It's not just that we bring things to them, what can they bring to us? Finally, I want to offer a hypothesis here that doesn't really have a lot of data, but I think follows a lot of our intuitions. The things that work are all these policies and programs that are direct behavior change. However, what makes those possible is a confidence in the system, a confidence in vaccination, a trust that all of these things that are going on are wholesome and are going to benefit our children's health and the health of the populace more generally. So having strong confidence may be a prerequisite for being able to do all these things that really work. So it's not that confidence doesn't matter, it's that when we think about confidence, we might want to be thinking about that high confidence could be the tool for making the public as well as policymakers open to the kinds of programs and projects and policies that are particularly effective in increasing vaccination. So having said all that, hopefully we can enact some strong policies. We can start to overcome some of the instability that we've had recently in vaccination coverage, especially for and including HPV vaccination coverage, which is still quite low in the United States, an area for urgent intervention. But also we have other things we need to address. We need to get flu vaccination up this year. We need to use flu vaccination as a model for getting COVID vaccine delivered. And in the fall, make sure that we have high rates of flu vaccination so we don't have a dual pandemic on our hands of global flu vaccination as well as global COVID vaccination. And then hopefully in the spring, maybe later next year, we'll have a COVID vaccine and be able to use our tools to increase vaccine uptake. But wishing and hoping and doing a bunch of media campaigns is not the way that's going to be most effective. We need to build our programs and make them concretely effective on the ground with lots of strong logistics. Thank you very much.